the meeting. The first 2 hours of this meeting was a complete disaster because once we started to brainstorm, it was just completely a storm, and we were thrown away here and there. How are we going to do it? It's not possible. We have a major problem because screening based on risk factors ain't going to work, and we have many reasons to say that. You'll see the pictures, and they can speak for themselves. We didn't kill anybody, but we were very close. We were successful in managing human rights, and we ended up having a very peaceful conclusion after 2 days among, as I said, different groups with different attitude towards practice and science, and indeed a very wide range of expertise in the room. Well, finally we had early fall relax, and we came up to this. Well, what is the reasoning? Reasoning was simple. As you see in this slide, 70.6% of American adults have one or more risk factors. On the other side, about 20% don't have any risk factors. If you look at the slide that was shown by Dr. Ritker, you'll see there is a great overlap between CHD and non-CHD death as far as cholesterol. Indeed, majority of coronary heart disease occurred in people with average cholesterol. Well, average cholesterol means about 140 million Americans. How are you going to screen 140 million people? If you want to listen to Dr. Ritker, you have 76.5 million Americans with high CRP. This is a new enhanced report. If we want to listen to our colleagues who, like Dr. Greenland and others who were pioneers and indeed taught us the concept of risk factor, you're in a bigger problem. What the problem is, this paper was published by Dr. Greenland in JAMA last year, not for the conclusion that I'm making, for the opposite conclusion. The risk factor needs to be considered as the core element of coronary artery disease prediction. But you'll see, if you walk with me through this slide, you'll see why the conclusion is not accurate. Well, focusing on the first one, which was Chicago Heart Association's data, you see that people with CHD and people without CHD, very little difference, 90.6% versus 83.1%. This is a huge problem once you have the factor that you call it risk factor so commonly found in the control group or in non-CHD group. The same thing with Mr. Feet data, 76.5 versus 64. I just picked up the main population list, but this trend is similar throughout the different age groups and sex groups. This is the Framingham data. Again, 91.5% were this category, cholesterol, and 86.8%. They didn't have any event. Well, despite the conclusion that Dr. Greenland, the correspondence, which also was published a few months later in JAMA, made a really nice calculation that if you put the sensitivity and the specificity, you come up with something like this, that the likelihood ratio is only 1.3, going based on risk factors, and cholesterol being the center. Well, I have a very simple analogy, and I learned it from my epidemiology teachers. It's just like smoking and lung cancer. We don't have the position to say that smoking is not a risk factor. Of course cholesterol is a risk factor, high LDL, low HDL. There's no doubt about it. But in a city that almost everybody smokes, you're not going to be able to use the smoking as a predicting factor. There's no way. The prediction is zero. And this is where this society is going with this rapidly growing epidemic of risk factors, obesity and metabolic syndrome and so on. I borrowed this slide from my colleague John Rumberger. It's a powerful slide the way he put it, and of course the study was very unique too. 222 people, men, aged less than 55, very active and productive part of our society. If you look at their, and they had heart attack, they had acute coronary event. The day before their acute coronary event, if you evaluate them based on current guidelines, this is what you find. 6% qualify, not qualify for therapy, and 6% would qualify in the group that are classified high risk, more than 2% annual risk. The intermediate group, if you put them, again, the day before the event, would have 8% not qualified, 10% qualified, and overall 18% this group. And if you go after the most important part of this, you will see that 61% of these people who already had heart attack, if they were evaluated based on the current NCEP guideline, they would not be qualified for therapy. John has a very passionate speech on this. I'll leave it for him if he's sharing the same slide. So bottom line was, our meeting after many hours and discussions came to land on this conclusion. The conclusion was, screening for prevention of heart attack, again, heart attack is our broad and general term for acute coronary syndrome and sudden cardiac death, must be established as a standard of practice in preventive cardiology. This is very important. Comparing to most cancers, we established a screening guideline. Screening for prevention of heart attack is more cost effective. Current risk factors are not desirable for screening and should not be used as a first step because of high prevalence, less than desirable predictive value, and numerous risk factors, more emerging coming. Risk factors are best for guiding and monitoring therapy. Non-invasive tests capable of measuring the disease structural and or functional at the arterial level should be considered as the first step. This was our bottom line conclusion in the meeting that everybody agreed. And one of the things that Erling brought up, very nice contradiction, is American Heart Association, American Cancer Society, and American Diabetic Association came to this common ground guideline. I want to walk you through this guideline. Well, this guideline says you do this if you are after age 20 and recommends the screening, and government pays for these screenings. So this is the prescription for reimbursement. Well, see what we have here. Number one killer, coronary heart disease, only has a blood pressure measurement once every 2 years. If BP less than this, or at least, it says every 2 years, basically. And a cholesterol test every 5 years. That's all coronary heart disease gets from the national budget. What others get? Well, if you just look at the one portion of cancer, which is breast cancer, mammography and clinical breast exam is part of it in every 3 years. Colorectal screening after the age of 50 is part of the reimbursement. You have to get it, and the price here is $1,200 to $2,000. Bottom line, this is what we have come to agree as our first draft of the chart, the guideline, and this will be published in the next few weeks more. And with this meeting's brainstorming, we will have it more crystal clear. But I'm going to walk you through this briefly. The total number of Americans, 45-year-old men and above, female 55 and above, is 77 million, about 77 million, according to national data. Out of these 77 million, drop 12 million is their average number of coronary heart disease, non-coronary heart disease. You end up to 55 million. So 55 million are people who are the bottom of our pyramid now. And if you subject them to one of the tests for atherosclerosis, and Erling is going to tell you test for disease versus test for risk factor, you will come up to this too based on the data that is available to us. We've based most of our data on coronary calcium because the data was more abundant, but carotid IMT as well. About 30 million 12 here and 25 million here. And this test positive will fall into 3 subcategories. If you are more than, for example, coronary calcium score 400, or percentile and coronary score more than 90% and 100, and carotid IMT of such, you will fall into a screening for very high risk category. And in these 2 categories, the name are adapted from American Heart Association and NCP's classification: lower risk, moderately high risk, and very high risk. See the value of risk factor here in detection? Almost nothing. There is no value for risk factor here. We're looking at the disease. Why are we obsessed about risk factor? We use risk factor for therapy and guiding the detection. Now, this is the last part, that having the systemic markers like markers of inflammation like CRP and LPPLA2 has been discussed and is being considered for further recommendation and depending on data. The functional and structural tests are being listed here. These pictures are part of our report. And the last slide is on our future direction. We believe that our group has to push for future, and the future is where you have non-invasive molecular imaging of plaque inflammation and non-invasive coronary endothelial function added as functional components. And that was 45 years and older. You also have to consider the group that is between 20 and 45 years, and this is what we're going to discuss tonight in our discussion panel. With that, I'd like to conclude. We did conclude our meeting, and I hope that this is the last slide. I hope that we're able, with our efforts that goes well beyond academia and having symposium. We've just recently sent a letter to President Clinton, which to our belief is the icon of a vulnerable patient, to join our campaign, and hope we will be able to get his support. With that, I'd like to go ahead and introduce our next speaker, Dr. Fuster, who has kindly agreed to share with us his latest thought in the field. Dr. Fuster is no stranger to people in the room. I personally consider myself a student of Dr. Fuster.